Thank you very much. And I try to be as objective as possible because we are in the postprandial period, so maybe a little bit somnolence. Okay, so I'm talking about this therapy that is intrathecal transplantation of autologous cells, autologous bone marrow-derived cells for cerebral palsy kids. First, just who is into basic research in the room? Basic scientists, yeah. Who is in the clinics? Who is clinician? Yeah, not a lot of us. Who is here? In between? I think that's the idea of being here, okay? So, but also the idea is to avoid tangles and promote communication between clinicians and basic scientists. It's just, and now we are talking about personal issues, who is who. I just want to say that I'm living there, not there, that is Schönbrunn in Vienna, but I'm from Mexico, and that's Playa del Carmen. That's very nice, right? And then I try to live in love, and this is my kid. He's trying to be doctor, maybe. I don't know. Okay, so getting to the business. So whom is not familiar with cerebral palsy? It's a highly prevalent disease. It's a motor impairment. It's a syndrome of motor impairment that results from different lesions in the developing brain. We know that about 20% of that is because of asphyxia in the birth. We know also that 85% of the kids have an abnormal MRI, and we know that 50% around have generalized epilepsy, okay? So this is not a fatal disease because they live a long of years, most of them, not long, but they are not dying in the next 2 years. But the quality of life, it really sucks, sorry. This is one example. This is one of our patients. And if you see, he is now not working. This is the one. So as you see, this is, they cannot sustain the head. He's around 3 years old. He cannot sustain the head. He cannot move the legs. It's barely unable to sit by himself. And he's already 3 years old, so that's basically not normal. And really hard to live like that, okay? Then I'm sure everybody in the room has some relation to some kid like this because of the highly prevalence. Then, how is the management now? How we have, what as a clinicians, what we are able to do for these kids? So basically, there's a lot of things, most of them directed to reduce the musculoskeletal deformity, but none of them is directed to the primary cause. This is a brain lesion. Then all of the intervention that is physical therapy, some rehabilitations, except for the surgical orthopedic interventions that are intended for the deformities, they have weak scientific evidence. So we are doing that with weak scientific evidence. So the clinical practice is based on series of cases and also in the expert guidelines that we all know how these work. There's another treatment for specific symptoms, and there's neurosurgical intervention to reduce the spasticity. There's orthopedic intervention. There's pharmacologic intervention to reduce some of the symptoms that they have. A few parts of the treatment are intended for neuroprotection. That is in an acute scenario, and then it's like hypothermia, magnesium, and other medications that are intended to neuroprotect. That is maybe this should be the intention of the treatment. Then we have autologous bone marrow-derived stem cells that 90% of the guys here knows a lot of these. So basically, that's the lesion. There's an acute event, there's cell death, there's metabolic responses, there's inflammation, and further damage, and then permanent lesion in CNS. Stem cells, there's publications that they can be involved in several of these steps in more or less intensity in the acute event or in the subacute event or in the chronic or permanent lesions as trying to regenerate. That is highly, it's a very nice discussion, but could be also a regeneration, okay? What mechanisms we know that they could be involved is plasticity. That is the first one that everybody a few years ago were very, very excited about that. Now we know that probably is not the main effect. And then the paracrine effect, as the doctor was saying here. And also one group in the University of Vienna, the study about the secretomes, that when the cells are dead, then they liberate something that could function as trophic factors. Then we know cytokines, growth factors, then they can differentiate. There's also publications about the synaptic reconnections. So mainly, if we want to put it in 2 words, we want to neuroprotect and neuroregenerate, okay? What we do is we took around 200, less than 200, sorry, from bone marrow. Then we put it in a machine. The machine is basically nice view of a centrifuge. Then it separates the cells. It goes one part the stem cells, the mononuclear cells, and for a part the plasma, the bone marrow-derived plasma. There's no manipulation. It's a closed system. Even from the European medical agencies, that is considered manipulation because they are using another part that is not the same intended. And then this bone marrow collection, just to have this in your mind for the next slides, they prove this also in the acute phase. All the patients that we treat are chronic patients, but this was done also, not by us, but by other group, but Cox, in acute patients, and there was no disturbance in the hemodynamic or in the acute phase of the patients. Just keep that fact in mind. Then after 25 minutes of the process, we take out the mononuclear cells, then we inject 5 milliliters intrathecally, and then we inject 5 milliliters intravenously. And then we measure the CD34. I know there's more to measure than CD34, but we measure just CD34 to know how the counts of these cells. Then we measure also vitality of the cells after the procedure, not in between the procedure. Why we use intrathecal infusion? Because it can induce differentiation of stem cells into neurons. That's pretty new, and before that we start doing this, but it's a new release. Then because of the roads, if we put it IV, we have the filter of the lungs, then we have the blood-brain barrier, even if there's also a description of open the blood-brain barrier with mannitol, and could be, but still, as you see in the most part of the people using stem cells, they use culture cells and they have millions of cells. And if you use it in the OR and with a point-of-care method, you cannot get a lot of cells. And maybe very important for these kids. Then, so we inject it intrathecally or intravenously. Then, so we have 80 patients, around 6.4 years old. From those patients, 39 had also epilepsy, 16 was stroke-related, 24 had structural defect like corpus callosum agnesis or other thing. 10 of these patients were treated twice, and then one of these patients were treated a 3rd time in a period around 6 months in between. What we measure was side effects as our main point of measure. Then the classification system, that is gross motor function, that is the mainly affected in these kids. And then information for the caregivers. As you may know, these kids are 100% with a caregiver. They cannot be by themselves. And then we have a questionnaire about this specific motor and other skills to ask. We perform electroencephalography in the case of epilepsy and an MRI. The results, 83% of the patient, 83% of the patient was treated intrathecally and intravenously. 11% were treated just intrathecally because of the disposition of available bone marrow aspiration that we could not get more stem cells. And 6% were just treated IV because they had some kind of contraindication like a VP shunt that could make an embolus. We didn't have any major side effects. Around 20% of the kids had a mild headache that disappeared after 2 years, no, after 2 or 3 days. 50% of the patients improve in this scale. This scale is in years, it's groups, and it's 5 levels. 5 is the worst and 1 is the best. Then I put this example here because it's very difficult to go from step 5 to level 4 because it includes a combination of a lot of improvements in strength, in cognitive, in coordination, in reduced spasticity, etc. So 55% maybe doesn't sound really cool, but it means they improve a lot in a lot of aspects of the clinical aspects. Then 90% of the patients improve in one of these these skills. The most important were the spasticity and the motor skills, including walking. Then the second treatment, in 10 patients, just one of these patients improved again in this scale. That was not expected because if we, as one of the doctors that talked before, more than one treatment could improve more because there's more cells and second intervention, but it was not like that really. Also, if you scale and the worst patient may improve, or you can see that they improve more because they are worse, or it was not expected. But was less, the amount of improvement between the first and the second, and between no treatment and first and second was less. None of the patients found any kind of changes in the electroencephalography and no changes in the MRI. The one patient that was treated one more time after a year had no further improvements. Minor improvement in spasticity, but not in the scale. Without a statistical significance, we compare patients that were treated before 2 years and then after 2 years, and then compare about the time and trying to look for which patients benefit most from the treatment. We find a tendency that patients before 2 years improve better, and the patients with hypoxia, but without any statistical significance. We have a lot of limitations of the study. First was a pilot study with a lot of patients. Then the group was heterogeneous, mainly because cerebral palsy is like that. There's no control group. We could have done more objective clinical trials and maybe another kind of imaging study that give us more information, and a couple more of limitations of the study. For the basic scientists, that's one thing that could be very nice to do is to track the cells in the CNS, and then we can actually see, because we injected in the lumbar puncture, and we can actually see if they are getting to the right place that the cells should be. Conclusions. Today, the clinical practice to treat motor impairments in patients with CP is based, as I said, in case series and expert guidelines. These medical interventions describe when they work, it's temporary, improves with high frequency, and there's a lot of medications that have side effects. So, as a group of people trying to cure or to get better these kids, we need some suggestions, and treat patients with autologous bone marrow could help in the future. And I want to show you this video of one of the patients. So this was before the treatment. He cannot handle the head easily. He can stand. That means he's not in the deep stage of the scale, of the gross functional motor scale. And he can barely move the legs, as you saw. So that video is around 5 to 6 minutes, and he is just standing. Then after the treatment, he's not walking alone, I know, but he is sustaining the head, and he can move the legs, and he can make all with assistant. That means that was the mother was the assistant, but with an assistant device, he could walk also. So the patients treated, the patients that we treat, basically were worst cases, the worst cases. Thank you. Around 6 years after the diagnosis. That means the acute event of hypoxia, if it was the case, was already done. And this is just after 6 years of the body trying to improve with physiotherapy and other things. One good thing to do with the future clinical trials is start treating patients in early stage. And this is not just for CP, it's for Alzheimer's disease. If we treat the patients that are after 10 years of diagnosis, it mainly doesn't make sense. I know if it's someone in ethic commission here, maybe he's about to shoot. But it's the truth that we have to start earlier, especially in neurological diseases. And don't wait until they come to the office and say, yeah, there's nothing to do, so go home. Okay, and personally, the translational research can get us there. If we start basic science, start to prove these things that we can get easily to the clinics, maybe another story in the next conference. We know with these patients that the treatment is safe, not just for these patients, for another publication of CP patients, intrathecally administration, there's even some research that are doing directly in the brain. What can we do next? Double-blind clinical trials, but I put it as a question. Do we really can do that to kids, a double-blind clinical trial? Just to leave that in your minds. And treat acute patients. We know it's safe. We know that take bone marrow from the patients in an acute phase is safe. So could be something that we can do, and multi-dose clinical trials. And the next step is prophylaxis when are risk births. There's a high incidence of risk births, especially in non-developed countries. And I know that was not politically correct, but this is something that is preventable. And if it's not preventable the first, we can have a prophylaxis. If you remember, I showed that and I stopped because I think I have 1 minute, but this is short. This is the kid that you saw in the first slide, that he cannot sustain the head and he cannot even sit alone, and he's now assistantly walking. I know these are the best cases, but because I want to show you this, and this is part of an anecdotic case, and we cannot take it into account for starting the guidelines. But as I said, the guidelines now for this disease are based in the clinical experience, not in scientific evidence, or some part of them. It seems that in therapeutics, the amount is important, maybe the amount of cells, and in research, it may be, that less is more. The easiest sources of cells may be the answer and not our PIMP cells from laboratory. And then, okay, there's no time for flash news. And this is the team. And thank you very much for your attention.
So we have time for one quick question and a quick answer.
Thank you, Luke from US. Very encouraging with preclinical data. So do you have any other quantitative evaluation data for these kids? For instance, before and after their muscles, intentions, and
Even objective studies,
Yeah,
like
yeah.
myography,
Yeah.
no, we don't have it. So we have some of them, but we just put the ones that all of the kids have performed. And